At this point, I'd like to introduce our next speaker. She's in the back of the room, so if I can ask Kathleen Bennett to come forward, and if we can take our seats as we prepare for the last panel. You know, the last panel kind of gave us a nice segue into the discussion that we're about to have on hospitals and the impact of for-profit hospitals moving into the state. But before we do that, we're very pleased this morning to have Kathleen Bennett, who's the Director of Policy and Strategic Planning from the New Jersey Department of Health and Senior Services, here to speak briefly and give us all kinds of insight during this important period in New Jersey. Kathy, thanks so much for being with us.
Good morning, everybody. On this rainy morning, I too made it here despite the accident on 195, and I saw other people wandering in at about the same pace I was. So I'm glad to see everyone here today, and on behalf of Commissioner O'Dowd, I want to thank the Council and also Becky for hosting this program on the state of health here in New Jersey. Today's program addresses healthcare landscape and the steps we are all taking to strengthen the healthcare delivery system in our state. I've met with a lot of you since I joined the department about a year and a half ago as the Director of Policy and Strategic Planning. And together with our partners from the Camden Coalition of Healthcare Providers, the Trenton Health Team, and the Newark Healthcare Coalition, we're engaged in new ways of delivering coordinated care to our most vulnerable residents. With the Healthcare Workforce Council, which is chaired by Bob Wise, who spoke earlier, we are considering the changing landscape of healthcare delivery, and we're anticipating what the needed workforce is in the coming years. And through the Health Information Technology Commission, we are updating our Health Information Technology Plan to enable the timely sharing of medical information among providers so that the right information for the right patient is available at the right time. These last 2 years have marked a transformation in the hospital industry, and Bill Conroy, our Acting Deputy Commissioner for Senior Services and Health Systems, is going to join the last panel today to speak about it a bit more. But we've seen that some hospitals have merged into larger systems, others have moved into state-of-the-art facilities. In addition, national and local for-profit hospitals have expressed interest in bringing capital to invest in New Jersey's healthcare delivery system. We've had the pleasure of attending several ribbon cuttings for new facilities, Virtua in Voorhees, Capitol Health's Hopewell campus, and just yesterday, the University Medical Center of Princeton at Plainsboro. We've also seen the transfer of ownerships, Newton Medical to Atlantic Health, Hoboken University, Warren, and those planning on transfers, Mountainside and Christ. The openings of new facilities mean greater access to health care for our residents, but they're also representing significant investments in our local economies, taking health care into the next century and ensuring the utmost quality of care. One of the accomplishments that the department's enjoyed over the past year and a half has been the startup of the Office of Healthcare Finance, which is in Bill Conroy's branch. Joe Lario is heading up that office, and he comes from the hospital industry. And he's helped us think about new ways, new comprehensive ways of viewing hospital financing. The governor's proposed reorganization of state government in his budget creates a significant change and opportunity for the department. We're going to be transferring senior services to human services. This consolidation is going to coordinate all funding, policy decisions, and services for seniors into a single agency, the Division on Aging Services at the Department of Human Services. This transition is going to be seamless for seniors, and it makes sense because all Medicaid long-term care services will be part of managed care under the Medicaid Comprehensive Waiver. This realignment gives the department the opportunity to sharpen our focus on key public health issues. We're looking at things such as the burden of chronic diseases like cancer, diabetes, heart disease, HIV, and obesity, which have a disproportionate impact on certain populations. More than $828 million of our nearly $2 billion budget goes towards public health services. 80% of that funding goes out in grant funding. DHSS has core programs that invest in our healthcare safety net and support services to New Jersey's vulnerable populations. The governor's budget provides more than $1 billion in funding to maintain his commitment to ensuring access to services for the uninsured. Federally qualified health centers will receive $46 million in reimbursement, and hospitals will receive $961 million in subsidies to support their services to the uninsured. The New Jersey Cancer Education and Early Detection Program which provides cancer screening for more than 18,000 low-income individuals, is supported in this budget with $6 million in state and $3 million in federal funding. The newborn screening program will receive $6.5 million. And last month, which was Autism Awareness Month, Governor Christie highlighted his budget's ongoing commitment to services that support children and adults with autism. New Jersey has one of the best systems in the nation for identifying, for diagnosing, and for caring for children with autism. A critical component of this commitment is our department's early intervention program, which is funded at nearly $140 million and serves infants and toddlers up to age 3 who have developmental delays and disabilities, including autism. This year, my office will be awarding up to $8 million in autism grants to create a center of excellence and to support research and awareness, research and treatment. This will be through the Governor's Council on Autism. In addition to consolidation of senior services, 2 state programs that provide funding to hospitals, Graduate Medical Education Program and the Hospital Relief Subsidy Fund, will be transferred to the Department's Office of Healthcare Finance. Realignment will enhance our efforts to improve the predictability and transparency of hospital funding for the benefit of hospitals. The Governor recognized the need to increase stability in the healthcare environment and made a strong investment. Despite economic challenges facing the state, the Governor has preserved hospital funding. Charity care funding is maintained at $675 million. Graduate medical education funding remains at $90 million. The Hospital Relief Subsidy Fund remains at $165 million. And the Healthcare Stabilization Fund is maintained at $30 million. Stable and predictable funding supports the financial viability of hospitals and allows them to pursue their mission to serve their communities. The Governor also provided more than $46 million to federally qualified health centers to care for the uninsured, and we are encouraging New Jersey's hospitals to partner with their local FQHCs to leverage efforts to improve their community's health. In addition, to promote collaboration and planning, the Office of Health Information Technology, which is responsible for the implementation and facilitation of health information technology across the state, will be transferred to the department within my Office of Policy and Strategic Planning. The ever-changing healthcare environment often dictates what issues confront the department, and there are always new and unexpected challenges. However, Commissioner O'Dowd has also chosen issues where she feels she can make a difference. Her priorities are healthy people and healthy communities, working smarter, and palliative and end-of-life care. With limited state dollars, our Shaping New Jersey program has teamed up with 180 leading health, nutrition, fitness, business, and community leaders to prevent obesity through nutrition and education. Childhood obesity has tripled here in the state over the past 30 years. 24% of our residents are obese, and New Jersey has the highest obesity rate among low-income 2 to 5-year-olds at 17.3%. Through Shaping New Jersey, we are working towards a shift in culture that recognizes the importance of nutrition and physical activity in all of our environments, where we work, where we live, where we play. In the past, obesity prevention focused on the individual, but Shaping New Jersey focuses on creating environments that support healthy behavior to make the healthy choice the right and easy choice. As part of Shaping New Jersey, we have also focused on increasing breastfeeding rates in our state. Infants who are breastfed for 9 months have a 30% reduced risk of being overweight. We have supported 10 hospitals with grants to become baby-friendly. South Jersey Healthcare at Elmer recently announced that they were the first baby-friendly hospital in New Jersey, and they were one of our grantee hospitals. Capital Health also received a baby-friendly designation. An example of creative partnerships is a recent collaboration with the Healthcare Association of New Jersey. This demonstrates, how we are trying to work smarter as a department. Rather than only regulate minimum standards in our assisted living facilities, we are asking providers to go beyond the minimum, to strive for excellence and be rewarded with a special designation called Advanced Standing. This will provide consumers with quality benchmarks for the first time. Other things that we've done over the past year have included the Universal Transfer Form. We're the first state in the nation to have this form. All information, vitals, meds, diet information, travels with the patient in a concise, standardized, one-page form. It reduces the chance of a hospital or nursing home getting incomplete information about what medicine a patient is taking, so it's going to help reduce medical errors. Another example of working smarter is our ambulatory surgery website. It's another tool that consumers can use when making healthcare decisions. It makes healthcare more transparent, and it helps keep consumers informed. This expanded website allows the public to examine inspection reports for 260 licensed or certified ambulatory surgery centers. Easy access to more information so they're empowered to make more informed healthcare choices. As a matter of fact, next week we're going to be working with our partners from AARP to test the user-friendliness of this tool. We want to make sure we put the information in the hands of the public in the easiest way possible. The department is re-examining all grants to ensure that we're maximizing our resources and we're focusing on outcomes. In March, we announced $8 million in HIV/AIDS grants, and increased funding went to places like Henry J. Austin Health Center in Trenton because of its comprehensive approach to care. They have consolidated all services in one health home, minimizing barriers for patients and improving health outcomes. Community mobilization grants that are awarded through our Office of Minority and Multicultural Health have also had great success in reducing school absences and pediatric ER visits due to asthma. We've seen up to a 60% reduction in school absenteeism, and we've seen a 67% reduction in ER visits among our population in the program. End of life is another important issue for the Commissioner, and she recognizes that caring for a loved one in the final stage of life is a painful experience for the entire family, but it is particularly difficult when medical decisions need to be made without knowing the wishes of that person. We need to do more to educate, to promote discussion, and advance individual decision-making to help families work through these complex issues. Working with the New Jersey Hospital Association, we are creating a new tool for providers called the Physician Order for Life-Sustaining Treatment, or POLST. This law, which was recently signed by Governor Christie, allows patients to outline the kind of medical care they want at the end of life and makes it easier for providers to honor their wishes. In February, the department chose NJHA's Institute for Quality and Patient Safety, which is a federally accredited patient safety organization, to develop the form and help plan its rollout to both providers and consumers. Elaine Holmes from the NJHA is leading the effort, and the work group began its meetings in March. The POLST, signed by a patient's attending physician or advanced practice nurse, provides orders for healthcare personnel to follow for a range of life-sustaining treatments, such as feeding tubes, ventilators, and medication. In the early development phases, nurses and other clinicians will be essential to the development and success of the POLST. We're beginning to see the power of data sharing and coordination among providers. As we all know, the costs of inappropriate ER use are enormous. Through the existing health information exchanges, we are able to provide services to high-need patients, which results in significant ER diversion and improved quality of life for patients. I'd like to focus on 3 of the regional planning efforts that have been taking place in New Jersey over the past few years. First would be the Camden Coalition of Healthcare Providers and the Camden Health Information Exchange. The Camden HIE has been operating since 2010. All hospital systems in Camden are connected, and by December 2012, it is projected that all providers in Camden will have access to the HIE. The HIE operates in real time with direct interfaces to each of the member hospitals. When there is an event in the hospital, such as an admission, discharge, transfer, or diagnostic result, that data immediately flows into the HIE. The availability of the data to identify high utilizers between healthcare providers and therefore better coordinate care for those individuals is yielding multiple successes in the care they receive. Just one example, a 52-year-old diabetic woman was confined to her room due to complications from her illnesses, and she was admitted into the hospital on average every 29 days, in addition to multiple ER visits in between. After intervention from the Camden Coalition, the woman avoided ever visiting a hospital for 10 weeks continuously. Similar experiences are being had in Trenton. The Trenton Health Team is a collaborative alliance comprised of the City of Trenton, all 3 of Trenton's hospitals, Capital Health Mercer Campus, Capital Health Fold, and St. Francis, as well as Henry J. Austin Health Center, Trenton's only FQHC. They have a dedicated executive director in Ruth Perry. Our department recently provided a grant of $400,000 to help with their health information exchange. One of the things that the Trenton Health Team has done is that they've actually incorporated something called advanced access scheduling. All 7 of their outpatient clinics, run by the Trenton Health Team members, drastically improved patient encounters with the healthcare system, specifically focused on shortening the length of time to appointment, improving continuity of care by achieving consistency in the matching of patients with the specific healthcare providers, and increasing the number of patients seen. The healthcare providers implemented numerous activities to achieve the set goals. They identified the need to get those affected by sickle cell into primary care. I think one of the big ahas that came out of sharing data amongst all of the partners within the region was identifying what was one of the leading causes or drivers for continuous ER admissions. And in Trenton, that turned out to be sickle cell. So, due to strategies that they've employed from March 2011 to 2012, the following successes have been achieved. St. Francis focused on improving continuity of care. Initially, continuity was 0. In 1 year, the hospital achieved 95% continuity in patient visits by assembling 3 teams of resident physicians to see recurring patients. Henry J. Austin improved the rate of providing patients with the 3rd next available appointment from 37 days to 2 days. And Capital's Health's Family Health Center increased its demand from 18 patients per day to 21. The Trenton Health Team is making continued progress in reducing the recidivism rates of frequent ER users in Trenton. In one example, a patient made 64 visits to the ER from 2010 to 2011, and 6 were extended hospitalizations related to complications with diabetes and kidney disease, among other conditions. After engagement by the Trenton Health Team, that patient incurred 0 ER visits the following year, complied with treatment recommendations and dialysis, and avoided hospitalization completely the following year. In another example, a female patient had 465 ER visits in 2010, 400 at St. Francis and 65 at Capital Health, due to mental health issues, substance abuse, and homelessness. The Trenton Health Team got her an apartment and outpatient mental health services, and in 2011, the lady made only 12 visits to either hospital. Finally, Greater Newark Health Coalition. Their HIE is called Healthy City, and it allows the 8 hospitals in the network to exchange records with one another and with the ambulance services, physician practices, and visiting nurses. I started my comments, and I'm ending my comments today, acknowledging the importance of care coordination, of health information exchange, and engaging with multiple providers in order to improve the quality of care and patient outcomes. We appreciate the commitment to enhance the quality and delivery of care in our state by all our stakeholders, and we look forward to working closely with our partners over the next year in ensuring our residents' health is protected. Thank you.
Thank you, Kathy. We thank you for your time here and your remarks this morning, and also please send our gratitude back to Commissioner O'Dowd for her recognition of the importance of having these discussions about healthcare in New Jersey. At this time, if our last panel could assemble on stage, we were going to have a discussion about the impact of for-profit hospitals in the New Jersey hospital landscape. Beth Fitzgerald is our moderator. And those of you who have been around New Jersey a long time, like I have, remember Beth from her days at the Star Ledger as a business reporter and business editor, more recently at NJ Biz and currently at NJ Spotlight, as certainly one of the preeminent, if not the preeminent, healthcare business reporters in the state of New Jersey. So we're delighted to have her moderate the discussion this morning, and she's joined on the panel by numerous dignitaries here. And I think we're just about to assemble. Our mics are working here. So, Beth, you want to test and see if you're on?
Is that pretty good? No?
I don't think we can hear anything at this point.
It's claiming to be on.
Yeah.
Allegedly, it is on.
Yeah.
No? Still nothing?
Yeah. I think we'll have everybody working in a minute. So.
I'm not going to do much talking, so it's really not going to matter.
Great.
You're going to be hearing from people who actually know something about healthcare.
Set?
How is that?
Okay.
Is that better? That is better. Okay, great. Well, we're going to be, obviously, we're going to be talking, as you know, about the future of for-profit hospitals in New Jersey. To my left, we have Bill Conroy of the State Department of Health. To his left, I'm sorry, I want to get everybody's name correctly, Robert Wise, President and CEO of the Hunterdon Medical Center. To my right, we have Derek D'Elia, Associate Research Professor of the Rutgers Center for State Health Policy, and to his right, Steve Kirby, co-founder of the Community Healthcare Associates. I'd like everyone to really speak about the future of for-profit healthcare from your perspective. And I really think it would be great if we started with you, Bill, to talk to us about what how the state of New Jersey sees the recent past, I guess, of for-profit hospitals and what the future will be.
Okay, great. Thank you, and good morning, everybody. I was recruited to come here to talk about the experience on for-profit hospitals, and I don't know if you know this, but we've had a for-profit hospital established in New Jersey 11 years ago in Salem. So we had our first at that time, and we are now approaching almost 12 hospitals in the state. So we've had a relatively recent, rapid conversion in the ownership of hospitals by for-profit entities. So it's something that is changing, and it seems to be changing now rather rapidly. So my first reaction to this is we really have to stay tuned. We're not sure where we're going to end up. It's starting, and we're going to have to wait and see ultimately how we settle in our state with the balance of for-profit hospitals and not-for-profit hospitals.
Is this a good thing? Is this something that's good for New Jersey?
Well, I think that when the state deregulated rate setting in the early 90s, hospitals were then tasked with negotiating commercial insurance rates and managed care rates, and it really changed in the 90s. And for the hospitals that struggled with their finances, it becomes more and more difficult for them to stay afloat and to also modernize. As an industry that's constantly evolving with technology, getting money to make the proper capital investments becomes a problem. So to the extent that for-profit organizations could come in and assist in a hospital's modernization, redevelopment, and also pay taxes, we feel that that's a positive development. Moreover, the most important thing we think is that patients continue to get access, and whether it's nonprofit or for-profit, they have to play by the rules. They have to follow the rules around compliance, for licensing, for charity care. And our state was wise enough to require that people could get care even if they didn't have the insurance, through charity care. And hospitals, for whatever inpatient service they choose to operate, must also provide outpatient clinic services. So there's some effort to have some continuity of care. So, I hope that sort of answers the question about whether or not it's a good thing.
Well, maybe we should throw this to you, Bob. You're running a not-for-profit hospital.
Yes.
How do you view the entry of for-profit hospitals into New Jersey? How does that impact your industry?
Well, this is not new to New Jersey, even though it may have started in a rush most recently. For-profit hospitals have been around in New Jersey until 1982. American Medicor owned 3 hospitals in the late 70s and departed when the DRG system was introduced in, I think, 1982. And Humana had hospitals in South Jersey. There may have been good reason for them to depart because of course, control on their ability to maximize profits, which is really a significant basis for for-profit hospitals to operate. They have shareholders. Not-for-profit hospitals obviously have the community where they return whatever margins they're making back to the community in the form of of new programs and services or possibly reduce cost. So the perspective has changed somehow back to what may be to for-profits an opportunity for them. Besides the elimination of those controls back in 1993, what for-profits may be seeing is the vulnerability of not-for-profit hospitals. New Jersey ranks 44th in the country in profitability. As of 2010, the average margin for hospitals was 2.4%, where across the country the average is about 5.5%. Also was given, as of course not-for-profit hospitals across the country, a negative rating by Moody's for 2012. So we're in, quote, common company, not good company, as a not-for-profit. And that means that hospitals in New Jersey either must compete strongly with for-profits, and that is they become somewhat like them, seeking ways to find margins more so than what inpatient services are providing. And that means clinic programs are less emphasized than ambulatory initiatives, wellness centers, even high-level selective inpatient services where margins are reported supposedly to be more lucrative for hospitals. And of course that creates the question of excessive services. So for-profits see the Dartmouth Atlas study as much as not-for-profits do. And they see that we are a high-cost operation. They believe, I'm sure, that they could reduce their costs through their efficiencies faster and easier than the not-for-profits that have been struggling in the state.
Okay. Well, I'd like to turn this over to you, Mr. Kirby. You have been on both sides of this fence, so talk about your history in the industry and what you're up to now.
Well, I'll let Bob act as the administrator of a suburban hospital, and I'll take the role of a CFO of an urban hospital because I spent probably 25 years in either Newark or Jersey City, and I wasn't. If I was a for-profit CFO of one of the new companies that have come in, and I heard what was said at the earlier panel that there may be an increase of 450,000 Medicaid beneficiaries created by some of these programs they're talking about here in New Jersey, I wouldn't have a warm and fuzzy feeling if Medicaid's paying me 70 cents on the dollar. So I'm not so sure I want, as the for-profit CFO, more Medicaid business. And I know I don't want more charity care business. So as Bill Conroy said, the jury's out. It's going to be very interesting to see after they stabilize and start operating their hospitals, the for-profits, what happens to those patients that are paying less than costs. Because as Bob said, they're in the for-profit business. They have shareholders to report to. They don't have a moral compass from a group of board members that are interested in what's going on in the community or with their hospital. I am stunned over the amount of money that was just paid for Mountainside Hospital. And for those that don't know, it was $190 million. And for a for-profit joint venture to come into New Jersey and spend that kind of money on that facility, which historically has just barely made it, and replace another for-profit hospital that decided after 5 years they wanted out of New Jersey.
And sold it for $30 million.
The first time.
Yes.
Yeah. So when it's exponentially gone up in value, and I just can't figure out how they're going to make any money on it. Again, the jury's out, and I'll tell you a brief story of what happened to us at Jersey City. A hospital built 75, 80 years ago, completely archaic, was replaced in 2005. We built a new hospital for the price of $225 million. And I heard earlier everybody talking about these new hospitals are going to open, Capital and Virtual, et cetera. We opened up a brand new hospital in 2005 at that kind of cost, picked up $18 million a year in debt service. And of course, Medicare won't pay additional debt service, neither will Medicaid or charity care. So you're kind of going after the HMOs to pay your debt service. And we had an 18 to 20% increase in volume, but 7 months later we realized it was all charity care. So we're an urban hospital, we can't pay our debt service. So when I called up the regional vice president of one of the largest insurance companies in the country, I said, listen, I have all this debt service. You have to increase my rates by 20%. Without blinking an eye, he said, Steve, I didn't tell you to build a new hospital. And that was the end of the conversation. We didn't get our debt service paid. So I'm not exactly sure how Mountainside is going to make carrying this $190 million worth of debt. The for-profit company, I just don't see it. So the jury's out until we see what happens.
Could you also talk a little bit about what your business model is now and how it's kind of a hybrid of for-profit and nonprofit?
We found a niche. We recognized that all these buildings were going vacant. The state would know better than I, but I suspect 25 or 30 hospitals have closed in the last 10 or 15 years, and you have all these empty hospital buildings. We bought the Barnard Hospital out of bankruptcy, and unfortunately we did it in 2008, in the beginning of the economy, the real estate crisis. But in the last 4 years, we have retrofitted Barnard into a medical arts complex. And we're doing the same thing with the bankrupt Hospital Kessler down in Hamilton, where we take the hospitals and try to entice local docs, surgeons, imaging center, pharmacies, et cetera, to reopen the building, and we're just a landlord. And they come in and reopen it and hopefully work off each other's strengths and cross-refer within the building for all of the different services their patients may need. So when a patient walks out of a cardiologist's office, he walks right past a pharmacy, right past a laboratory, could get an x-ray, and we hope that there'll be some synergies within this group. And so far, our two buildings have been extremely successful. I'm not saying that'll happen. We were asked, the Department of Health has been extremely supportive of us, and both administrations have supported this. You get to a place like the Trenton facility for Capitol Health, which is a huge building in downtown Trenton. I'm not so sure that's an answer. I'm not so sure we have an answer for that type of a facility.
Okay. Derek, what is your perspective on the changing landscape of in New Jersey? What are you concerned about when you look at it in terms of public health, quality, economics?
Yell. Can you hear me now? Okay, good. Okay. Well, I think we can learn a little bit just looking at the experience of what's going on in other places around the country. This is certainly an issue health economists have been looking at for a few decades now, the issue of what is the difference between a for-profit and a not-for-profit hospital. In a nutshell, what the literature says for the most part is we haven't seen a whole lot of difference between for-profit and not-for-profit hospitals in terms of the quality of services that they offer. Much of the differences that we see is where do these hospitals locate? Touching on some points you made, for-profit hospitals often don't go to the poorest areas where there's a lot of uninsured and Medicaid. If they do, they might enter an area where there's already a public hospital that sort of carries the weight for charity care, and things like that. Also, we've seen empirically that for-profit hospitals tend to respond more rapidly to changing market conditions. So if things are looking tight, if an area is not generating the financial returns that they originally thought it would, for-profits tend to be a bit more mobile. They'll shut down or relocate or change their service mix. Not-for-profits tend to be a little more stable and sort of toughing it out, and they have a community that they serve, and even if it's not profitable, they'll be much slower to move or curtail the less profitable kinds of services. Another point between not-for-profit and for-profit actually touches on something that Kathleen Bennett mentioned very briefly, this idea that hospitals also are really large employers for their local area, that they generate broader economic activity. And just more broadly, even going beyond the hospital sector, not-for-profit hospitals tend to be not just hospitals, but firms, tend to be a little more employee-oriented, trying to provide stable employment when things get tough, less likely to just let people go right away. For-profit firms are a little quicker to sort of, again, respond to market conditions, and you have to let people go. You let them go because your ultimate goal is to provide a product for the end user, the consumer, and you have to answer to your shareholders. Some economists say this is good, this makes them more efficient, but if you look at it more broadly, treating your workers well and not just laying people off quickly is sort of, it has value for our economy as well. I guess the only other point I would make is everything we know about for-profit versus not-for-profit hospitals depends on the environment in which they operate, particularly the regulatory environment. So in New Jersey in particular, we tend to have a more tightly regulated hospital market in the sense that, for example, all acute care hospitals have to maintain an emergency department 24/7. In other states, that's not the case, and if the EDs were attracting a less profitable patient mix, we've seen in California and other places, lots of hospitals have just closed the emergency department, which would not be an option in New Jersey. New Jersey also has stronger rules regarding providing care for people who don't have the ability to pay for it. Federal law says emergency departments have to screen and stabilize patients who show up. New Jersey is fairly unique in that the New Jersey law says you have to do more than just screen and stabilize. You have to provide all necessary care. And so if you were a for-profit hospital, you'd be subject to those rules as well.
Bill, I'd like to ask you to address this whole question of the safety net hospitals in New Jersey. New Jersey makes these stabilization grants, and Christ Hospital got one. Christ is, about to be acquired, could be acquired soon by a for-profit. Same with Hoboken. Jersey City also has gotten they were trying to do a deal with Christ. They also got stabilization money. How do for-profit hospitals fit in with the state's really huge support of safety net?
Right. Well, just in looking, when you think about safety net hospitals, I think you have to look at it in the context of charity care, clearly. And really, so far in our state, we have 3 hospitals that have any kind of, for-profit hospitals that have any kind of history now where we could look at their documented charity care. The hospital in Salem, Bayonne, and the Merritt Hospital, Mountainside Hospital. And when we looked at their documented charity care over time, we have not seen any change. It's been relatively stable in terms of volume. But I would add the caveat that it's really, again, too soon because we don't have a length of time, and we don't have an entire, it's three hospitals, and for looking at Bayonne and Mountainside, it's really a relatively short period of time. So it's interesting what Derek mentioned about in other states, the for-profits will coexist with public hospitals, and there's a public hospital system. And New Jersey is unique in that regard too, because we don't really have, we do not have a public hospital system. And again, the regulatory approach in the state that is actively supported by the commissioner and certainly the governor is to require that all hospitals participate and deliver care to the indigent and charity care. So we have a unique model, and obviously, one size does not fit all here in terms of looking at the arrangement of healthcare services. I would add too that the for-profit hospital the executives that I've spoken with feel that ultimately their success will also hinge on their ability to build trust in the physician community, and the physicians are going to hold them accountable for quality and for access for patients, so that they're mindful of that. And if they fail to achieve that, and Derek also did mention that they looked at the comparison in quality, that there has not been a change. So I think for-profits are cognizant, excuse me, that they need to, pay close attention to that. But again, we really do not have public hospitals on our landscape. I don't see that, being something that gets developed here for a whole host of reasons.
Would anyone else like to jump in?
Well, I think the charity care safety net issue is a significant one. The number of charity care dollars contributed to the state's hospitals last year were $675 million. That's held steady, and we thank the governor for continuing to support the same level as the year before, but unfortunately the number keeps rising, so the gap increases. The documented charity care costs for the state's hospitals last year was $1.33 billion. So the difference is a significant one. And then there's a significant variability among the hospitals as to the formula that they apply for receipt of those charity care dollars. Hunterdon Medical Center received a reduction of about $300,000 of charity care last year, even though our costs went up about $1.4 million of charity care, which equates to about 24 cents on the dollar. And as you know, in any business, you really can't do well over the long term with that kind of a formula. The business model just doesn't work. Thus, the acute care model for hospitals in New Jersey is at risk. They're well overbedded, and that's demonstrated by the reduction in the occupancy rate, on average occupancy rate of hospitals, and compels hospitals, as with Hunterdon, to seek partnerships, ambulatory programs, and other opportunities within our mission, charitable mission. More than 60% of our net revenue last year was in non-inpatient services. And the reason why we were profitable at about the national average. We began that program, that initiative, nearly 20 years ago, slowly investing in services that are near the consumer's home, ambulatory programs, outpatient services, as we saw the reduction in inpatient rates occurring and now accelerating. And I do think that acute care hospitals who aren't looking beyond, we, by the way, employ over 100 doctors at Little Hunterdon Medical Center, but they are physicians who are committed to our community, 80% of which are primary care physicians. And really that is a significant answer to hospital and healthcare systems. It accesses population health, it's a door to the home, it's a relationship with the family, and it's a referral, obviously, to your own network within your community. But every hospital needs to be right-sized for the community it serves. So regardless of the number of beds or the cost of investment, if it's not right-sized, if there's not an assessment of the community healthcare needs of a community, I think there's risk of failure.
So that's very interesting. So you're saying that the future model, business model for a hospital might be that you have an emergency room, you have intensive care, and in between you're really filling it in with as much outpatient and ambulatory care as you possibly can, since they're not even, they're going to send you home on the same day with a hip replacement? We're getting to that? Well,
some hospitals in different states don't have intensive care. They are referral centers. They agree that should there be a need for intensive care, they will transport that patient to an intensive care center. Hospitals in New Jersey have traditionally accepted the general hospital model. The specialization that you see in other states has not yet occurred, except in pediatric facilities and psychiatric hospitals. So I do think, again, the right sizing of your your community to institutional needs needs to be strongly assessed. For example, investing in an intuitive robot in the OR will increase the cost of that procedure by $3,000 with no additional reimbursement. And if you don't have the minimum volume to pay for that $4 million piece of equipment, you're losing money, even though it's prestigious to make that investment.
Okay, great.
I was intrigued by the outpatient comment. And Bob mentioned that New Jersey is overbedded, and I think the bed count for Hudson County is 400 to 450 excess beds, as that came out in the Navigant report, which is probably the third or fourth report that's been done in the last 10 years that hasn't really been implemented. But the outpatient scenario in Hudson County and in Newark is totally charity and Medicaid. So for a hospital to expand its clinics, and I saw Kathy Grant Davis before, I don't think she's here. I don't know how many, maybe Bill knows how many of the federally qualified health centers make money. But unless you're on top of your game, you don't make money in these federally qualified centers if you're heavy urban presence. And we haven't addressed what happens when a hospital has to think of more creative ways to make money in an urban environment. I tried to cancel a contract once with a major payer, and in a nonprofit environment, I was pressured by my board, who in turn was pressured by the local mayors not to drop a certain payer, because all the policemen and firemen and school teachers were covered under that contract. So in my negotiations, I was coerced not to take a bold step. And political pressure, board pressure, whatever, the for-profits don't have that pressure. They will take that step, and when you have an out-of-network model that is making $18,000 to $20,000 a day in revenue or cash collected versus $2,000 or $3,000 a day for the nonprofits, then the scales start to tip a little bit, and you have to wonder whether that for-profit model is appropriate. And I think that's what Bill means by keeping an eye on this over the next couple of years, because the hospitals in the suburban areas, the for-profits may do very nicely, getting larger contracts. The bigger you are, maybe a better contract you can negotiate. But if you're in an urban environment, you start canceling these contracts, you're now living off of somebody else's money. And that's the fear, I think, at least if I was the state, I'd be afraid that all the hospitals would drop contracts. A lot of the surgery centers are out of network. And you're hearing these stories of $20,000, $25,000 charges for a 10-minute pain shot. So there's the down and dirty side of the for-profits that has to be thought of as we go forward.
Sure. I just want to comment on the...
They're out to get you.
There it goes.
How about now? Here we go. I just want to comment on the issue of too many hospital beds in New Jersey. I think it is an issue, but a bit more nuanced than the way most people talk about it. So if you look at New Jersey compared to the rest of the country, we actually have below average number of beds per capita. And of course, the United States is actually behind most industrial countries in terms of the number of hospital beds per capita. It's not just the number of beds, it's really the cost per bed and the intensity of service provided for each patient that's occupying a bed. And that really speaks to broader issues involving care coordination and how services are reimbursed. We certainly pay and spend a lot of money on very intensive care. New Jersey is actually, off the charts on this one in terms of how many physician consults take place per patient in the hospital, how many specialized services are provided. So just taking the beds out of service doesn't necessarily get us to where we need to go. And we've actually done the 20-year experiment on this in New Jersey. We've closed a lot of hospitals. We've taken a lot of beds out of service. And costs didn't go down. They've gone up and they're accelerating. And it's because of the intensity of service per bed. And you deal with that issue through broader health reforms that we might talk about that can be done at the state level. And certainly the federal level tries to move the needle in this regard in terms of accountable care organizations and how we pay for different kinds of services.
I do think, however, that if the regulations that allows for more of a fluctuation or transition for hospitals to receive licensed beds approval or to de-license them would encourage them to take a more frequent look at their fixed costs. Right now they're holding to their license capacity. They may not be staffing to that capacity, but they're fearful that if they delist or de-license their beds, that they will never get them back should there be a growth of the population in their service area. So I do think that is an issue of opportunity for the state to allow hospitals to take a more right-sized look at their fixed costs through that mechanism.
Do we need to get a lot more money into New Jersey, into the hospitals? Is that
Absolutely.
a problem here?
I think in the right places, however. I think that if we talk about a hospital, it may not be where the best investment could be for the long term. For a health system, we talked about coordination of care, we talked about team care, we talked about extenders in services into the community. I do think that there are many opportunities. We have a national model in Camden with Dr. Brenner. We have success across the state in some community programs, and I think that's where the investments need to be made to be able to reduce the high cost of care until it's transitioned out of the model and the practice that we see demonstrated in the numbers in the Dartmouth Atlas study.
Yeah, just in terms of trying to generate revenue for an industry, what you're seeing is a tightening under Medicare. You're seeing a conversion into Medicaid managed care. As a result of going into Medicaid managed care, states can no longer use the gap between Medicare and Medicaid to apply for supplemental funding, like the money that's funded. Kathy Bennett made remarks about GME funding of $90 million and $166 million for Hospital Relief Subsidy Fund. That money is funded through upper payment limit funding that recognizes the gap between claims paid from Medicaid versus Medicare. The federal government will not recognize that gap under managed care. They only recognize it under fee for service, so it becomes something of a catch-22. And in order to get a waiver under that, to continue that money, states are now being asked to go into something called delivery system reforms and I think innovations and performance, DSRIP. So if you go on the internet and you type in DSRIP, you'll see the states that are now fully involved in trying to implement these reforms. But the long and short of it is, a lot of the expectation by the federal government is to shift the development and the investment outside of the walls of the hospital and into the community and rebalance the money toward primary care so that individuals can get more ongoing community-based services and not need hospitalization. So it's going to be more and more of a challenge for hospitals.
Yeah, and I recently saw a pie chart that represented the cost of health care in different segments, and attributed 51% of the total cost of health care to lifestyle. Smoking, obesity, poor exercise habits and the like, and only 15% to hospitals. So what the federal government, obviously, in knowing that pie chart, is doing is shifting the obligations to change lifestyle habits to the hospitals at a significant expense, of course, to do that. The reimbursement is not there. So they have to take their not-for-profit status and make the risk to their community a real one. And that means balancing the profit, or the mission and the margin. And it's a delicate balance when the margin is declining or is marginal. You can't be innovative as much as you'd like. The for-profits can be, perhaps more so. And that's why there is a place in New Jersey right now for the profits, because they're taking risk capital, and they are investing it in areas where they're struggling hospitals. to see if they can resurrect them. And in some cases, they have been successful.
Could someone address, what are, I guess, some sort of long-term criticisms and I guess, suspicions of for-profit hospitals that there's this tendency we have seen among some of the for-profit hospitals to be unwilling to be in insurance carrier networks, and then there is this concern that they're working for their shareholders, they're not working for the community. So maybe Bill, you should.
I'll take a stab at that. I think in terms of obligation to investors, yes, but also in the context knowing that you must obey the rules of the game for what you're doing. So again, there's an expectation that whether you're for-profit or not-for-profit, you must deliver care to anyone who shows up and needs the care, regardless of their ability to pay. So you have to do that. There's no way around that aspect of providing services in our state. That's I think probably the major distinction. I really that would be my main point on that.
By the way, I encourage you to take a look at a white paper created by Leland Brewster, B-R-E-W-S-T-E-R, 59 pages. The title is The Effects of For-Profit Hospitals on the Quantity and Quality of Care Provided. An excellent reference on this topic that spans all of the issues of higher mortality or not, better quality, lower costs, and why.
You hear me? I'll just talk loud. I would just add that in regard to a for-profit hospital, maybe not serving particular communities, not accepting certain insurance, the state does have a tool that it might use to monitor that. Years ago, they passed the Community Health Assets Protection Act, which says if there is a for-profit conversion, the state could appoint an independent access monitor to keep an eye on what happens at this hospital, and that would become a condition of the sale, that you have to do this monitor has to be put in place. We actually did this for the Salem conversion years ago, I think it was 2003, at the Rutgers Center for State Health Policy. We did this monitoring to keep track of, was there a real change in the pattern of services provided in the local community, and I think the state could do this on a case-by-case basis if a particular conversion people didn't have the right comfort level with it. Rather than just say no, you could say, well, sale is conditional on having a monitor, and if something looks wrong, then the health commissioner can act on that.
Did you want to try and get a question from Becky? Okay, so we're going to wrap up, I guess. Okay. Thank you very much, and please let's all thank our panel here.
There's a question.
I'm sorry, do we have one question?
We'll do one question. We have time for one.
Marcia Atkins from the Healthcare Foundation of New Jersey.
Hi.
I wanted to go to something that you touched upon but you didn't really discuss, and that is the possibility that for-profit hospitals may not provide care in areas of care that are not profitable. For example, women's health, eye problems in newborn premature babies, retinopathy and prematurity. These are things where there are insurance issues, where the care doesn't pay for itself, and for-profit hospitals may drop that kind of service. Would you address that?
Well, I can, again, refer you to that document where there is some evidence that they are selective in their choice of profitable services.
I would also like to add that under licensing, again, regulations in the state, if a hospital is seeking to eliminate one of their services, it's incumbent upon them to demonstrate that there would not be an access problem for individuals in that community. So we would ask, what is the alternative for patients in the event that the service closes at that location? So that would be very important. And likewise, the whole issue of, it was brought up about contracts with managed care and commercial insurance. During transactions of hospitals, hospital ownership, that's regulated under certificate of need. So another tool the state has is to impose conditions on hospitals that are above and beyond the standard set of regulations. And in the area of of insurance, we are getting more savvy as we go through more applications, and we are very interested in, our jurisdiction certainly is in Medicaid managed care. We want to know what the obligation will be for the new entity going forward, and we'll ask them, are you going to participate? And if not, we will expect that they address this as an issue. And then lastly, just in general, I think the best we can do right now in our state is to ask the two parties to come together and perhaps consider mediation as a means to getting contracts together. And you know, there's some hesitation on both sides because they're concerned that giving this information out, this proprietary information on fees and payments to third parties, they lose control of it, and it loses, you know, it impacts their ability to negotiate.
By insurance, I really meant non-private medical malpractice insurance, not coverage.
I see.
Yeah. Please join me in thanking this panel for an excellent discussion.
Do you share the information?
The council would like to thank you all again for coming out today, and we'd like to again say a thanks to our sponsors, MD Advantage, the Nicholson Foundation, and New Jersey Manufacturers. I think the tone today has been one of optimism in spite of the obstacles that we face. So we invite you to stay tuned and join us next year for New Jersey State of Health 2013. See you then. Thank you.